Welcome, everybody. Thank you for joining our webinar for today. I'm Andrea Vasquez. I'm a family doctor in Regina, and I'm co-lead for the project on the knowledge mobilization of the guidelines and these webinars. And I want to welcome to the Division of Continuing Medical Education Post-COVID Condition Winter 2025 webinar series. I want to mention this is a project with the University of Saskatchewan, but also in conjunction with the McMaster University, Cochrane Canada, and the Canadian guidelines for the post-COVID condition. And the recommendations that will be made here are based on these guidelines, which are in the process of being posted and getting to know to everyone. So the presentations will be delivered in English, but French captions will be posted with the recording after. So as we gather here today, we acknowledge that we are on Treaty 2, 4, 5, 6, 8, and 10 territories and the homeland of the Métis. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another.
Okay, so we have two quick polls before we start the webinar. The first one is to find out who is in the audience. So this will just come up on your screen now. Please select your role from the list so we can see who is in the audience. And I'll give you a little bit of time to do this. Thank you for participating. So I can see we have many physicians in our audience today. We have patients with post-COVID-19 condition. We have some of their family members as well. We have nurses and allied health professionals and a few researchers as well. Thank you for taking part in that first poll. The second poll will be launched now. This will come up on your screen. So please rate your knowledge level about the following post-COVID-19 condition topics before attending this webinar. Okay, thank you everyone for participating in this. I will close this poll in 5 seconds again. Okay, and I can see for the impact of cardiac symptoms within PCC on patients and families, we have low to moderate knowledge level. For evaluation, diagnosis, and management of patients presenting with PCC cardiac symptoms, we have low to moderate again. And then for the third point, CAN-PCC guidelines for cardiac symptoms and management is also low to moderate. So thank you for taking part in those polls. This session is accredited. Following this webinar, you will receive a certificate. And please raise your hand when the Q&A is launched. You can use the Q&A function, or you can raise your hand and come up on the video as well to ask any questions during the Q&A period. And these are the steps we have taken to mitigate potential sources of bias. I will hand it back now to Dr. Vasquez to introduce our two speakers today.
Excellent. Thank you so much, Nina. So I'm very happy to present and introduce now our speakers, as I have had the honor to work with both of them. So the first one is Dr. Gavin Oudit. He's a professor, staff cardiologist, and clinician scientist at the Masankowski Alberta Heart Institute in the University of Alberta. His clinical and research activities places a primary emphasis on heart failure, cardiomyopathies, and COVID-19 impact on the cardiovascular system. He currently holds a Canada Research Chair in Heart Failure, Director of the Heart Function and Cardiomyopathy Clinics, and he's a fellow of the Canadian Academy of Health Sciences. And Dr. Andrea Lavoie she is an assistant professor, staff cardiologist at the Mosaic Heart Center, University of Saskatchewan in Regina. Her clinical and research activity places a primary emphasis on interventional cardiology with an interest in heart failure. She's currently the medical lead for the Division of Cardiology in Regina and president of the Canadian Association of Interventional Cardiologists, and she's the current governor for the Prairies chapter of the American College of Cardiology. So welcome to both of you. Thank you so much for participating, and I'm gonna just let you start. Thank you so much.
Okay, great. Thank you so much, Andrea, for that wonderful introduction, and great to be here. Great to be doing this with the other Andrea, my cardiology colleague. So I work with Andrea on the PCC guidelines, and we're doing this talk here with Andrea, Dr. Andrea Lavoie, for also a cardiology colleague. Okay.
Thanks, Dr. Oudit. So fantastic to be with you all today. If you want to go next slide, these are our disclosures. So really, we want to spend this hour with you guys just discussing some of the importance of post-COVID condition and the impact of cardiac symptoms within that condition on patients and families, to describe the appropriate steps for evaluation, diagnosis, and management of these patients presenting with post-COVID condition with cardiac symptoms, and then integrate the CAN-PCC guidelines for post-COVID condition into healthcare practice for cardiac symptoms and management. And next slide, I'm just going to be trying to sort of set the stage for us. I just wanted to review what post-COVID condition is. And as most of you are aware, this is defined as usually appearing within 3 months of the acute COVID-19 infection and lasting for at least 2 months, with symptoms that may vary and can change or worsen over time and significantly impact daily life. So what we know is there are a large number of patients that will present with cardiac type symptoms and their post-COVID condition after their infection. And so this has obviously a huge impact on patients' lives. And we know up to 14.8% of adults with confirmed or suspected COVID-19 end up having prolonged symptoms. And that adds up to about 1.4 million adults across Canada. And so many of these patients will have cardiac symptoms such as chest pain, shortness of breath, fatigue, and heart racing, or feeling unwell from that perspective. And so often these are very similar to those symptoms that patients might present with cardiac disease specifically. So it is very challenging to try and understand how best to treat these patients and also to rule out other cardiac causes. Next slide, please. So I'm just going to walk you through one clinic in an afternoon that I had these 3 patients show up on my doorstep who had been referred to me. And I think they very much embody the complexity of cardiac symptoms and post-COVID condition, as well as the pathology that comes with COVID-19. And so I just want to walk you through to set the stage, and then we'll have Dr. Oudit kind of go into much more depth about our diagnosis and management of these patients. So case 1 is Sarah. She was a 40-year-old woman with no past medical history at all. She had COVID-19 in August of 2024. And then I saw her in December with persisting fatigue and shortness of breath for about 4 months that had began. And so she was referred on to cardiology. She had an ECG, which looked normal. She had a stress test where she went 8 METs and had no symptoms. She then went on to have an echocardiogram that showed a dilated left ventricle with an ejection fraction of 35%. She had further workup involving a cardiac catheterization to rule out obstructive coronary disease and had no significant atherosclerosis noted there. Normal blood work with no other potential cause for her dilated cardiomyopathy. And she went on to have a cardiac MRI, which showed no evidence of myocarditis or infiltrative disease, normal structure, and an ejection fraction of 33%. So her diagnosis was a post-viral myocarditis, most probably. Next case. Case 2 is Scott. Again, young 37-year-old male, no past medical history whatsoever, and he had COVID-19 in February of 2022. So I saw him 2 years later with persisting fatigue, chest pain that came on at any time, but also noted with exertion. He had an ECG that was normal, and blood work showed a slightly elevated D-dimer at 536 that prompted a CTPE study, which was within normal limits. He had a stress test and had no ST changes, but did develop his typical chest pain on the treadmill. He had an echocardiogram that was normal, a gastroscopy that was normal, and because of the chest discomfort, he had a cardiac catheterization, which showed no obstructive coronary disease. Again, normal blood work with no obvious reversible cause. And his working diagnosis was post-COVID condition, chest pain related to the same. Next case, please. Case 3 is Jennifer. She was a 24-year-old woman, no past medical history. She had COVID-19 in March of 2024, and soon after started to notice persisting brain fog and had significant dizzy spells, especially when standing. She would find dramatic heart racing and palpitations, and so was referred on to cardiology. She was found to have a resting heart rate of 123 sinus rhythm. She had a stress test at that time, and aside from a resting elevated heart rate, she had no ST changes or chest discomfort, but did get dizziness in recovery. Her echocardiogram was within normal limits, and she went on to have a 10-minute standing test that showed no change in blood pressure, but her heart rate increased from 90 to 130 with symptoms of heart racing. So her diagnosis was postural orthostatic tachycardia syndrome and possible post-COVID condition. So I think these 3 cases are very illustrative of many of the patients we see on a daily basis in our offices, and many of you who are patients may have experienced some of these. And so with no further ado, I hand over to Dr. Oudit to talk more in detail about cardiac symptoms in post-COVID condition.
Great, wonderful. Thank you, Andrea, for highlighting those 3 real cases. And it just shows the complexity of the long COVID, post-COVID condition and the different manifestations of it. So what I want to do here for the next 35 minutes or so, and then be able to leave 10, 15 minutes for questions and discussion, is just to give a introduction to what COVID is and what are some of the players that goes on with COVID and long COVID. Go back to a bit of the symptomology and how we can investigate those, and the role of the CAN-PCC guidelines. And then I want to finish up with a very exciting trial that we're doing that came out of our research activities in COVID and long COVID. All right, so we have all heard about the microbiome. They're part of us, bacteria, viruses mainly. Here is an illustration from Scientific American about our virome. 380 trillion viruses make up the human virome. So lots of viruses, right? And so the SARS-CoV and SARS-CoV-2, and I had the privilege of being a trainee when SARS hit Toronto, and I actually worked through SARS, and so that was quite an incredible experience for me, experiencing SARS and dealing with here in Edmonton with SARS-CoV-2 and COVID-19. So but illustrated here is the many different type of viruses that can affect us, different organ systems. And here, of course, we're dealing with SARS-CoV-2, a respiratory virus. But I'll show you, this is actually not just a respiratory virus. It's a virus that can affect almost every organ of our body, and it goes back to the basic biology of it, okay? So the receptor for this virus, which we discovered in Toronto with Joseph Penninger, is something we call ACE2, so it's a membrane protein. And here, these are actually tissue studies from patients who unfortunately passed away from SARS. 34 patients in Toronto died from SARS. So I was a trainee back then, and we were able to show that there was, on the bottom panels there, you can see inflammation, macrophages in the hearts of these patients, and you can see this ACE2, the receptor, which is a very protective molecule, is downregulated, massively lost when you get COVID, when you get SARS, as it was called back then. So this is interesting in showing that you really get end organ damage, focusing here on the heart. On the right, we see the same thing with SARS-CoV-2 and in our COVID models. So we have both tissues from patients who unfortunately passed away from COVID, but also in the hamster model, which is probably the best model of long COVID. It's a model we have established here. And in both of these models, you see again inflammation. inflammatory cells in the heart, and this down regulation, loss of this protective molecule ACE2, which is the receptor for the virus. So you see it in the hamster hearts, but you also see it very importantly in human hearts. So in the bottom there, that's all data from patients who have passed away from unfortunately from COVID. And what you see, you get a few lymphocytes for those of you who are really keen in immunology, but you get a lot of macrophages and neutrophils. So there's something different about the inflammation that you get with SARS-CoV-2. You get both the adaptive immunity, so lymphocytes, but also the innate immunity, so macrophages and neutrophils. So this was quite unique finding, and it's also consistent with what we saw in SARS. So as you can see, lots of involvement of the heart. So not surprisingly, what Andrea's provided here an example of myocarditis, inflammation of the heart that you get with that you see in COVID and long COVID. The other piece to this is that COVID is a vascular disease. So moving beyond the heart now, it's a multi-organ disease, and that's how we really need to be thinking about it. And different patients can present with different combinations of those and organ involvement. So vascular effects is a big thing. And one of the second patient that Andrea provided was someone with elevated D dimer, suggesting that there was some platelet vascular coagulation defect in a patient, as subtle as it might be. And COVID is something that attacks blood vessels because guess what? ACE2 is expressed in the blood vessels in one particular type of cell called the pericytes. So in blood vessels, and the blood vessels are everywhere. They're in every organ of your body, and therefore ACE2 is in every organ of your body, and therefore SARS-CoV-2 can affect every organ of your body. Okay, so the vascular piece to this is also very relevant. It's relevant, of course, for the lungs, where you can have blood clots and vascular damage in the lungs. You can get it in the heart. You can get it in the peripheral vasculature. You can get it in the brain, and in the kidneys and in the gut. So we'll talk a bit more about that. So think about this as not only a respiratory disease, but a cardiovascular disease, and really a multi-organ disease. This is actually a paper from New England in the early COVID epidemic showing that you can pick up this virus in multiple different organs. Okay, so yes, it's respiratory, and you will get the highest detection rate of the virus in the lungs, but it's widespread. And here they're showing that actually you can pick it up in the kidneys, and we see this. We have published on this. You do get SARS. You do get COVID-mediated kidney injury and worsening kidney disease. So that's one of the comorbidities in a patient, and that is one of the silent ones. Your kidneys get damaged. You don't necessarily have pain and things like that. So it's always something to keep in mind. And so demonstration here that this is actually a multi-organ disease. And this is from our review in Cell that came out. And you can see in the middle panel there is a person with ACE2 expression coded. And you can see where is ACE2 most highly expressed. It's not in the respiratory system. It's not in the cardiovascular system. It's in the gut. So your gut, your small intestine, those little villi, a little protrusion in the intestine, are actually fully coated with ACE2. And so this is quite interesting. So not only is it in the lungs and forms the receptor for the virus, it's in the cardiovascular system, but lots of it is in the gut. And this explains a lot of the wastewater findings for COVID. You pick it up in the wastewater before you start seeing symptoms in the population and so on. But we now have evidence, both in patients and in animal models, that this gut involvement is one of the main driver of long COVID. And targeting this, I think, will be an important part of therapies, and we're starting to do that. Okay, so the virus is the receptor ACE2 is widely expressed, most highly expressed in the small intestine, in the gut, and therefore SARS and COVID are multi-system disease, and that's how we should think about them. This is not a respiratory disease; it's a multi-system disease. A lot of involvement of the gut, cardiovascular, CNS, and other organs. All right, so pretty important message here about ACE2 and the connection with COVID. Okay, this is just moving on to some of the epidemiological data. These are very large data set that came out from the US, looking at a very large cohort of patients, and you can see On the left there, patients who are hospitalized, non-hospitalized, in the middle, hospitalized, and in the right, overall cohort. You can see the multi-system manifestation of long COVID. Okay, and then that's how we should think about it. Patients who are hospitalized probably have a higher burden of higher risk of long COVID, but most patients now are not hospitalized, right? So this is not that's a bit of a bias based on what things were like 3 years ago. But now most of our patients are not hospitalized, so this is very relevant for the non-hospitalized cohort. And as you can see there, the symptomology is dominated by cardiovascular and coagulation. I would consider that to be equivalent. Musculoskeletal fatigue, and a lot in neurological manifestation and fatigue, right? So those are the dominant symptomology that you will see in patients with long COVID. All right, so pretty large cohort of patients here from the US documenting the multi-system burden of COVID and the daily lives affected. This is interesting. Coming back to the heart, this is actually came out a few months ago. This is talking about COVID as a vascular risk factor affecting the heart. So we've talked about myocarditis affecting the muscle, but clearly it's also an endothelial vascular disease. And this is data from the UK Biobank, where they've looked at patients with and without COVID, and they did a propensity matched cohort and showed that in patients with COVID, your risk factor is almost like you have diabetes or high vascular risk. Okay, it's almost, you can now consider this COVID-19 as a significant cardiovascular risk. Okay, so one of those newer risks because of the interaction with ACE2 widely expressed and things like the coagulation system and so on. So this is quite an interesting way of looking at it. Very well done study showing that this is really a significant risk factors equivalent to some of the more traditional risk factors. Okay, so we need to take this seriously. And obviously, many of you are already thinking about, oh my gosh, I need to control my risk factors very well. Absolutely correct, right? So treating dyslipidemia, diabetes, metabolic dysfunction, and so on, hypertension, and all of that is definitely all important in patients with long COVID. Because we really want to minimize your cardiovascular risk. Okay. And then let's not bias the studies from North America and from Europe, but you see this really globally, right? I mean, this is an epidemic. And I think one of the things this is what we have learned from this is that it affected everyone, right? So this is a study from Iran that I picked because to illustrate that in the Middle East and everywhere globally, patients are affected by long COVID, and this is no different, right? So high burden of symptoms in these patients, dyspnea, chest pain, and so on. So not at all surprising that these patients also all have long COVID. So it speaks to the diversity and things like that. And in North America and in Europe, patient visible minorities are affected a bit differently for long COVID, and in many cases have a higher burden of long COVID. So getting back then to the cardiovascular system, you can see the plethora of symptoms that you can have. I think Andrea went through a lot of these. You can have, your chest pain syndromes. You can have palpitation, shortness of breath, which could be cardiac, could be respiratory, can also be your muscle. Skeletal muscle is part of this, and a lot of the metabolic changes, even down to the mitochondria, those little organelles in your cells that make ATP, can all be affected. And so being short of breath could be cardiac, could be respiratory, can also be from your skeletal muscle function. Fatigue, again, multi-system, but common symptoms in our patients. And very interestingly, the third patient that Andrea talked about, POTS, right? So orthostatic intolerance, mainly with tachycardia without a drop in blood pressure. So kind of different from your other types of syncopal or vasovagal manifestations, but this is clearly a heart rate acceleration of heart rate with symptoms in patients with POTS. So in terms of so that's the summary of this. I mean, and we're going to start talking about some of the investigations and some of the future things that we could do for patients with long COVID. So again, just to highlight, the pathophysiology, of course, immune response, a vascular response. It really is multi-system, cardiovascular system, the gut, neurological system, but also skeletal muscle, and the kidneys are affected. There are risk factors for these conditions. Obviously, patients with pre-existing heart failure, patients with coronary artery disease, ischemic heart disease have a higher risk of developing long COVID syndromes. Obesity and diabetes keeps coming up in all studies as risk factors for COVID. And some of that we think is related to the gut and what's going on in the gut microbiota with COVID, and these changes in the gut and these metabolic changes may make us more susceptible to that long COVID syndrome. So we can also have other manifestations, hypertension, POTS, and even some types of arrhythmias. Atrial fibrillation has been reported. Okay, so this whole constellation of symptoms and different diseases that we can see affecting the cardiovascular system in patients with long COVID. Unfortunately, we do not have any, to summarize the treatment, we do not have any directed therapy for long COVID. Moderate evidence that a bit of rehab and exercise done carefully might help. But other than that, you're dealing with supportive therapies, okay? So treating your risk factors is obviously cardiovascular risk factors is obviously a key part of that. There is evidence that people who have been vaccinated may have a lower risk of long COVID. That's a bit less relevant now with the new variants. But that's basically it. So no effective therapy yet for long COVID, and I think the studies are ongoing, and some of those results will be coming out in the next 6 months to a year. And so far, what we have seen has been mostly negative or neutral findings. Okay, so this is obviously a big area that we need to invest and to study more. So. Okay, so this again is another illustration taken from the New England Journal of Medicine of what you see with acute COVID and how this moves into long COVID. So I want to say that long COVID initially was thought not to affect children or very minimally. That's incorrect. There is clearly a pediatric component to this, and kids are affected. Different age groups might be affected differently. And in adolescence, the GI manifestations of long COVID can be quite dominant. So in kids, it may be the gut may be more sensitive to long COVID. And so I think we need to think about our kids and how they're affected by long COVID. And it's also thinking about this is also think about how it overlaps with things like chronic fatigue syndrome, right? And I think as we're studying more and more long COVID, we need to think about how we're tackling chronic fatigue syndrome. So it's an opportunity to understand that condition also very well, and the whole concept of post-infectious conditions and the long-term sequelae of that. Okay, so as part of the Canadian PCC guidelines, I'm lucky to be involved in one of. So this is an illustration of what's going on at the CAN-PCC guidelines initiative. So there are 6 major groups of topics that we're tackling, with each of them have their own working group involved in the second one. So testing, identification, and diagnosis related to post-COVID condition, and that's the one I'll be talking about more. But you can see all of this, it ranges from prevention of post-COVID to healthcare utilization of post-COVID. Okay, so from the left to the right. And it deals with a whole host of things. We're planning to have these published, I think, in the Canadian Medical Association Journal, CMAJ, over the next 6 months to a year. And I think we're all really pushing to have these things completed and to be able to be made available to the public. So I'll be talking about the testing, identification, and diagnosis related to post-COVID now. So, okay. So the symptoms, obviously, chest pain, palpitation, shortness of breath, fatigue, I would definitely put in there. It tends to be one of those multi-system probably reflective of a multi-system involvement. So, but definitely cardiovascular, respiratory, skeletal muscle would be something that would contribute towards fatigue. Shortness of breath, dyspnea, of course, is there, and of course, pre-syncope or syncope is an important manifestation. You may see that as part of the POTS syndrome. Okay, so these are types of symptoms that we deal with. So in a way, very much like what you see in a general cardiology clinic. All right, so chest pain syndromes may reflect coronary syndrome, may reflect pericarditis, myocarditis. Right, so different type of chest pain, and so that's part of the investigation and the history and the physical exam. The dyspnea obviously may be respiratory, but may be cardiac, and you may get what we call heart failure with preserved ejection fraction. So the heart doesn't have to become necessarily very weak, but it can when you have a myocarditis, but it can also be relatively preserved pump function, and you can get something called heart failure with preserved ejection fraction. This, of course, the post-exercise malaise that the patients complain of. Palpitations are common, premature atrial beats, premature ventricular beats, atrial arrhythmias, atrial fibrillation, commonly being reported. And again, the pre-syncope as part of the whole POT syndrome. I think we're starting to do that, and I know our colleagues in Calgary have an important program in this. TIA stroke, again, part of the cardiovascular disease from some of the vascular involvement, thromboembolism, maybe from atrial fibrillation, but also from be a prothrombotic, procoagulable state that you get with COVID. And again, fatigue, we've talked about that being very complex, multi-system, but can be cardiac. Okay. Great. So these are, I think we meant to talk about this. These are some of the recommendations that are coming out. So strong recommendation there on the left, conditional on the right. Okay. So we've actually addressed this both for patients, healthcare professional, and policymakers. Okay. So a strong recommendation is something that most of us would expect to follow. A conditional would be something that negotiate with your healthcare provider, really maybe depending on some earlier findings or other findings in terms of how you proceed. Okay, so those are two unique definitions. Okay, so just going through this, and not all of this are complete, by the way. In fact, we just had a meeting before this webinar to finish up some of these recommendations. So here we're talking about ECG Holter monitoring, and this is we recommend the use of ECG in patients with suspected PCC long COVID and with cardiorespiratory symptoms. We think the benefits of doing this test outweigh any risk, which is very, very minuscule. And so we did give this a conditional recommendation. For most of what we're recommending, I would say the certainty of evidence is on the very low side. Okay, so that's consistent for most of what we're doing, but definitely recommend an ECG. Holter monitoring, again, based after a 12-lead ECG is reasonable based on the symptomology, things like palpitations, pre-syncope or syncope. You definitely wanted the Holter monitor to look for heart rate variability, to look for arrhythmias that you may not see in the ECG, look for heart rate changes, and so on. So I think a Holter test is something that can be used in patients with cardiac symptoms, and that's also a recommendation we have made. The 10-minute standing test, which I've indicated here, that's also a part of the cardiovascular assessment, but it reflects not only the cardiovascular system, but also the autonomic control of that. And that's the definition of POTS. Okay. So Andrea showing a nice example of that, where you don't get this drop in blood pressure, but what you get is this acceleration of heart rate. Okay. So it's something about the heart rate control and the autonomic instability and that. So that's an interesting condition, and I think maybe more in women than in men. And I think the whole PCC is more common in women than in men. For acute COVID outcomes, men seem to be affected more than women. but in the long COVID, women are affected more than men, and definitely in POTS, we see it definitely more in women than in men. So that's an interesting condition with a heart rate control, and there is a new therapy that people have tested and is published, ivabradine, so blocking the pacemaker current and lowering your heart rate might be something that's very unique as a treatment for POTS. Okay, so that's the 10-minute standing test is the test you need to do for that. Okay, great. So these are biomarkers. So in cardiology and cardiovascular medicine, we're lucky to have very specific biomarkers, and there are two of them. One is BNP or NT-proBNP, so the portion of the whole molecule, and that these molecules are stress markers. Okay, so when your heart is under stress, these markers go up. So someone with a cardiomyopathy, like our patient with myocarditis, someone with heart failure, these things are elevated. Okay, troponin I and troponin T is also very cardiac specific. They only come from the heart, but they reflect something different. They reflect myocyte damage. So if you're having a heart attack, if you're having lack of blood supply to the heart muscle, these would be elevated. Okay, so both of these are very cardiac specific, but they reflect slightly different types of cardiac injury. Okay, the natriuretic peptides reflect myocardial stress. The troponin I and T reflects myocardial damage. Okay, so they're part of a screening test you would do in patients complaining of long COVID and cardiac related symptoms. And so I think now most labs across Canada would have access to a natriuretic peptide assay. And we have now moved from regular troponin INT to high sensitive troponin INT, which would pick up much more subtle changes in these biomarkers. So I think it's fair to say across Canada, most clinical labs would have these tests, and they can be used to help you understand what's happening with your patients. So not only making a diagnosis, but they are very important prognostic markers. Okay. So I think one of the things we struggle with long COVID is that we don't always know what's going on. Quite often we don't know what's really going on. But what these markers tell us is give us some reassurance of the prognosis of our patients. Okay, so their outcomes. So if your natriuretic peptide are normal, if your troponin INT are normal, your prognosis is excellent. Okay, and you can give that recommendation. You can say that, give that advice to your patients when these biomarkers are normal. Okay, so if they're elevated, that suggests their ongoing injury and maybe requires medical therapies, require close monitoring, including follow-up on these biomarkers. Okay, so they're really important as part of the management tool, not only for diagnosis, but also for prognosis and follow-up. Okay, great. So some of these newer ones, we're still in the process of starting this out, and hopefully we'll have this completed in the next few months. But here is, for example, the echocardiogram. So this is actually from the American Society of Echocardiography. They actually had an update published recently. So this is taken from there. So for sure, cardiac symptoms, like I think our patient here with myocarditis, clearly Andrea did an echo and also a cardiac MRI. So really state-of-the-art care for this patient. So the echocardiography is widely available in most major centers, and it's the first test to use if you're looking for heart function assessment. And it gives you, of course, both the right side, left side of the heart, also looks at the pericardium and pericardial effusions and so on. So a critical test when you think your patient really have a cardiac diagnosis that you need to look into further. Okay, so there is recommendation on ambulatory oximetry, chest X-ray, PFDs, and pulmonary function tests. It's closely coupled to, of course, cardiac symptoms, and those I think will be addressed by other colleagues looking at more the respiratory component of long COVID. Okay, so this is like my one slide about therapies that work for long COVID. Not much. Okay, So sorry to be pessimistic about it, but really the only thing that seems to have worked is some sort of combined physical, mental health rehab. And this has to be done sensibly. This isn't your traditional cardiac rehab. Go on the treadmill, do as much as you can. Call us when you're having chest pain, right? This is a much more patient-centric rehab that also takes care of some of the mental health challenges that patients go through, dealing with post-exercise malaise and so on. So a program like this has shown to provide some benefit based on the systematic review. Unfortunately, all the therapies we have tried so far have been negative, including ACE inhibitors and so on. So I won't list all of those, but we really currently have no approved therapy specific for post-COVID. You would, of course, treat things like hypertension, you would treat dyslipidemia, you would treat diabetes, and so on. Those are all risk factors, comorbid conditions that should get treated as you would for any other patient, right? And again, please consider long COVID a significant cardiovascular risk factor. So all the more reason for these patients to be screened and to be treated accordingly. So I'm going to finish up here in the last 3 minutes and just talk about the program. This is the long COVID web that we've started nationally. And I think some of you are probably part of this. We also have patient partners. So we're the pillar 1, pillar 2 folks. So we're the basic biomarker folks, and here we're trying to look at biomarkers and thinking about new targets, new therapies, and so on. So that's sort of what been a big part of what I have been doing in particular, not only with our patients' biomarkers, but also in animal models. So this is actually data from one of our patient cohort that we looked at both acute COVID and then the long COVID. And not surprised, we profile all the inflammation, different metabolites, proteins in the plasma, and then we followed our patient. And not surprisingly, the pathways that we identify as important includes inflammation, platelet and coagulation, vascular disease, energy metabolism, which is a key one, really has a huge impact in skeletal muscle and post-exercise malaise. But we also picked up gut dysbiosis. Okay, so that keeps coming up in long COVID. We can't ignore it, right? So, and we did some more modeling on this, and it was interesting. One of the things that came out of this is a very interesting metabolite. It's called taurine. Many of you probably heard of it, and it's actually interesting. I studied this as a PhD student 25 years ago, and there's been other studies now looking at taurine, and in fact, taurine supplementation as a way of increasing longevity and decreasing senescence. It's a paper in Science, so very interesting work here at taurine. And we picked this up as one of the metabolites that when the values are lowered, makes patients more susceptible to long COVID. So we teamed up with Dr. Angela Chung in Toronto and our colleagues here in Edmonton and our colleagues in Montreal, and we put through a grant to CIHR, and we're lucky to have a 3-year support for this, looking at taurine supplementation as a novel therapy for patients with long COVID. I think one of the interesting impact here of taurine is it does have a lot of neurocognitive benefits in addition to effects on the gut, and so we're very excited that to be able to do this trial, and we're about to this week we're submitting to Health Canada for approval. So that's very exciting for us. So I'll just stop there, and I guess this is our concluding slides, right? So so I think part of this is just our understanding long COVID. The CAN-PCC guidelines are going to be really providing us with guidance and the 6 major areas and how to approach patients with COVID. And I think lots to do. Clearly, making the diagnosis and providing adequate education and support to our patients are important. Cardiology referral, as Andrea alluded to, when needed. And having patients involved in research and and all our ongoing activities are important. So I think we need to get to the bottom of this and to be able to start testing new ways of treating our patients with long COVID. I do believe the gut dysbiosis, the gut axis, is a key part of this, and probably very unique to long COVID. So I'll just stop there.
Excellent. Thank you so much to both of you for excellent presentation. And I want to invite people. I'm going to be reading their questions, and I'm going to ask if you don't mind to help us with answering those. So I'm going to go with what is posted in the chat. But thank you so much. Really excellent. Our third question is from, and I'm going to ask, sorry if I pronounce this name wrong, but Anne Peru. She said, did the biobank study also looked at the number of COVID-19 episodes versus cardiovascular risk?
Yeah, we so I guess a question for me. So we did not look. Yes, cardiovascular disease and cardiovascular events were part of that study, and there are two studies from that, one in hypertension and one in cell medicine reports. The one in hypertension dwelled more into the cardiovascular risk, and that clearly was significant in patients not only with in acute COVID, but also in long COVID. So I think the number of episodes clearly are linked to increased risk of long COVID. I think that's every study have shown that. And it's probably one of the benefit that vaccination has had, right, in minimizing the number of COVID episodes. So definitely, the more COVID episodes you get, the higher the risk is of having long COVID. Somewhat accumulative, I guess.
Lorraine, if you want to ask a question.
Yes, great talk, both of you. Really like this. If this isn't too complicated, can you talk about the interplay about fibrinogen clotting pathway, which some studies say is dominant, not platelets? And there's also the nets that one kind of the immune cell puts up across blood vessels. And in healthy people, it's to catch the gunk left over from an infection and get it out of there and recycle it. But they seem to endure in long COVID. So that's another way that clotting happens. And also, you mentioned antiplatelets and platelets, but the two studies I know of, one found no effect for antiplatelet therapy, and the other was stopped early because not only was there no effect, but it wasn't healthy. So what's our current state of knowledge? You say D-dimers can be slightly elevated or really elevated. Can you sort of talk about that?
Yeah, no, absolutely. So the antiplatelet therapies have been neutral or if anything negative and stopped. So absolutely correct. So they're not going to be the answer for this. So clearly coagulation is a complex process. You have primary hemostasis, secondary hemostasis, and things like fibrinogen and so on might clearly play a key role. The D-dimer is, when elevated, is an important risk that we see a measure of that vascular risk, coagulation risk. How we manage it is the challenge, right? So obviously antiplatelet therapy isn't working. I think there was a trial also with NOAC, wasn't there? That was also negative. So I think obviously if you're dealing with the PE or vascular thrombosis, then you would of course treat those patients accordingly. But beyond that, which is fairly rare in long COVID, but beyond that, treating this whole coagulation cascade has been very tricky. So not only antiplatelet agents have worked, your more secondary hemostasis blockers, things like NOAC, haven't really helped either. So very tricky, and obviously things like nets and so on from inflammatory cells, from neutrophils in particular, are very key. But how do we modulate that to as a potential therapy is very very challenging. But I'm sure people are working on that.
Yeah, I think fibrin really has come out even in the last month or two. And so I think that's opened a whole kettle of fish of research and knowledge now that people are going to be working on. to find out more of the details. We also know endothelial, function and how that's impacted may be a player in this as well, but that has been a years-long research in trying to understand that better and finding better therapies because of the lack of knowledge of the true mechanism of stimulation. And there's lots of nervous system theories and hypotheses as well. So I think you're right, it's complicated. And I don't think we're quite smart enough yet, but I think the whole world, this is the $1 billion question. I think that we're all trying to work towards. So yeah, great for bringing those up.
There is one study just recently published looking at heparin, which addresses fibrinogen. And I'm not saying that's the end all and be all,
Right.
but given during acute COVID, seemed to reduce the incidence of long COVID, and and continuing it also seemed to have beneficial effects. It's one study once, but any comments?
Yeah, I think we were involved in the heparin trials and they've been a bit mixed, to be honest. So we're having some ongoing looks at how that might be in terms of the long COVID. There's also been a few other medications such as metformin and other things that have been explored and decreasing long COVID. And so I think we need to utilize some of those tools that we know perhaps have had some signals. But I don't think it's been a slam dunk cause and effect that we would love to have in terms of, okay, we'll just give you heparin acutely and you seem to not get long COVID. That didn't quite bear out, and it depended on if you're hospitalized or not, etc.
Yeah, and this is where the biomarkers may help you, and maybe patients with elevated D dimers, maybe patients with there's also the fibrin degradation product that you might use that might be also helpful there to target that subgroup. This is a multi-system disease with that's very heterogeneous, and maybe we should be thinking about different therapies for different groups of patients. So if you have a coagulation vascular piece, then maybe that subgroup may respond somewhat to things like heparin. The metformin is interesting. It tackles how do you separate that though from treating early diabetes versus true long COVID? This question. SGLT2 inhibitors are being studied. There's the COVID trial that was negative, but long COVID, it may have a role again to provide further metabolic source for things like your skeletal muscle, and SGL2 might help in that regard. So I think that's also something that that people are actually looking at.
Thank you so much for those questions and answers. I want to go with the next question in the chat, which is from Dinah Kent. I have Wolff Parkinson White, and I was wondering if I have heart tests done, which I have not since COVID-19 diagnosis 3 years ago. Will it be possible to see the COVID-19 effects on my heart, if any, even though I have Wolff Parkinson White?
So that's a re-entry type of arrhythmia. So with WPW, you probably, I'm assuming you did not have an ablation, which in most cases would be curative. So that would be the way to address that. But I don't know of specific studies looking at the impact of long COVID and WPW. It's possible that it could lead to a flare-up of re-entry tachyarrhythmias. But again, it's something that you clearly would need to follow up with your cardiologist on. I think finding the path to an ablation is definitive therapy for this condition. So I would think this is something that your cardiology team would certainly want to embark on.
The ECG may not be as helpful as usual, as Dr. Oudit said, but unless you have other symptoms, we wouldn't see necessarily other effects specifically for patients with Parkinson White.
Quite often it needs an EP study and all those invasive testing, which now that restrictions have been lifted, we should all embark on those to get the right tests for your cardiac condition and get them treated appropriately.
Another question from Sylvie. Thank you for your excellent presentation. A lot of my female patients have a stress test clinical negative, but electrical positive. These tests are classified as false positive. Do you do extra testing with them?
So over to Andrea.
Yeah, I'll stick handle that one maybe. There actually are some new tests that have come out that have become much more elegant that we're embarking on finding out more information about these patients. So important to work on it with your cardiologist, but we are now doing coronary function microvascular testing, which can help include or exclude the possibility of coronary spasm or clamping down of the heart arteries, or if there is abnormalities in the kind of network of small blood vessels or microvascular disease. So there is testing now available across Canada. In Saskatchewan, I am doing the testing in Regina. And so if there's a question of whether there might be microvascular coronary spasm, you could have your family physician have you refer you to a cardiologist for further assessment to see if that would be appropriate or not.
Yeah, absolutely. And so in women, I mean, as Andrea alluded to, the presentation can be different, right? So you can get a microvascular problem and it speaks to long COVID, right? Being an endothelial disease. So you can also do things like coronary testing, endothelial testing to see if that's a challenge. And we do see that Minoka kind of syndrome more in women than in men. And it's something that long COVID probably does exacerbate. So it's something certainly worth testing for. Challenge there too is treating it is difficult. Maybe some role for nitrates and improvement in the endothelial function. But again, treating your dyslipidemia, treating hypertension, smoking cessation, so critical for all of those patients. So I think targeting your traditional risk factors are all going to be important in our patient population.
That's right. And there is some question about whether endothelial dysfunction may be involved in this, because a lot of, even in acute COVID, we saw patients coming in with big heart attacks on the ECG and clinically that they looked like they were having a massive heart attack, but their arteries were open. And so it appeared that there was some disconnect about what was happening at the muscle level and the heart artery level. And we've seen that kind of in the past and wonder if there could be some host viral connection. Again, it's a very complex disease that is probably multifactorial, and there's probably multiple groups in that type of chest pain syndrome that we're trying to learn more about. So there's actually a new Canadian registry that's going to be started to try and understand better the details of these patients. And we think perhaps patients with long COVID, specifically those with exertional symptoms, might be a part of that. And so there has been some preliminary smaller studies done in this testing post-COVID patients function, and that can again involve multiple systems. So there's a lot to be learned, and I'm very excited that now this research is happening. And I do believe and feel hopeful that with all the scientists across the globe working on this problem together, that we're going to continue to grow knowledge and not have patients feel like they're left in the dust with no treatment, because I know how frustrating and challenging that is when you're every day have symptoms.
Thank you very much for all the answers and all the comments. If you could please write down the name of the test you were referring to, that was a request. And for everyone, this recording is going to be posted with translation also into French, and all the captions as well included. So just for a matter of time, I know there was a second question, but maybe what I will do is ask for either of you just to write the answer for that question in terms of the POTS in patients, and then we can always send it
Yes.
as part of the email as a response, so we don't leave any of these questions unresponded. Thank you so much for the excellent presentation and all the comments and answers. I want to invite all of you to be aware of the resources for patients that are available in the CAN-PCC .ca website, which include the My Guide Long COVID Guide, the interactive infographics, online resources, and the webinars, of course, and also resources for healthcare professionals, also in the same website, which including the webinars which are accredited, online continued professional development courses, and the EVN Connect Canada. So thank you so much for attending. Please scan this QR code and to give us a complete survey about this webinar. And we welcome all the feedback, which will help us to improve in the upcoming ones. And here is to invite you to stay up to date and join in the website for information about the national guidelines on the CAN-PCC.ca website, and to check the recommendations that are available, and there will be more coming out in the same website. So thank you so much. And of course, keep you posted about the upcoming webinars in January and February as well. So you can explore more by scanning this QR code and visiting the website as well. So thank you so much, everyone, for attending. And thank you so much, Dr. Lavoie and Dr. Oudit.
Thanks for having
Great.
us.
Okay, guys, have a great day.
Have a
Thank
wonderful
you
day,
again.
everyone.
Excellent. Thank you so much.